Hello, everyone. My name is Andrea Wilson Woods, and if you can hear me and see me, would you please give me a thumbs up in the chat? Welcome to today's workshop, The Truth About Liver Cancer. Meet your multidisciplinary team, the medical oncologist. Today's workshop is produced by Blue Fairy, the Adrian Wilson Liver Cancer Association, a nonprofit organization. Blue Fairy's mission is to prevent, treat, and cure primary liver cancer, specifically hepatocellular carcinoma, also known as HCC, through research, education, and advocacy. We are so thrilled to have you. Now, today's workshop focuses on that multidisciplinary team, and this topic is so complex that we created 2 workshops. In April, we did a workshop focused on the liver disease doctors who may be part of your multidisciplinary team. And today, we're going to meet doctors who focus on cancer, specifically medical oncologists with expertise in HCC. This program, The Truth About Liver Cancer, has many sponsors, and today's sponsor is AstraZeneca, and we thank them for their support. Now, I'm going to walk you a little bit through the platform. First of all, you should be able to see a poll right now, so please take a look at that poll and let us know, what is your relationship to HCC? Are you a current patient? Are you a current caregiver of a patient? Are you a survivor? Perhaps you're a caregiver for a loved one. Are you a medical provider like our panelists today who see HCC patients? Are you someone who feels you might be at risk for liver cancer because of known underlying liver disease, such as fatty liver or hepatitis B or hepatitis C? Or do you fall in the other category? And if you fall in that other category, would you please be sure to let us know in the chat what that means for you? Again, I'm going to walk you through the platform, leave this poll up just a few minutes longer before we bring our first panelist up. So stand by. Dr. Liao is going to be standing by and joining us shortly. So again, please answer the poll. If you have any questions, do not put those questions in the chat. Instead, if you look at the bottom of your screen, you'll see Ask a Question. And if you click on Ask a Question, it will pop up and you will see some questions that people asked even during the registration process for this workshop. And please look at other people's questions. And if you like a question, you can upvote the question. You can vote it up. And so when we get to the Q&A at the top of the hour, about 1 hour from now, we will go through the questions, and the ones with the most votes we will answer first. And of course, we will do our best to answer all of your questions. In fact, we have 4 questions so far, and this is fantastic, and we've just started. So once again, if you have any questions, please put them in the Ask a Question. And also, you'll notice at the bottom, there is a little button, green button that says Support Blue Fairy. Please support us. Any gift you give us is 100% tax deductible, and your gift allows us to continue to do free programs like this for our community. All right, let's get started with our very first panelist. And I have to find him and invite him to the stage. We are bringing to the stage Dr. Andy Liao. Dr. Liao is a medical oncologist and an expert on liver cancer, bile duct cancer, and gastrointestinal neuroendocrine tumors, also known as GI NETs. Dr. Liao currently leads the University of Chicago Medicine's Gastrointestinal Oncology Program and is co-director of the Neuroendocrine Tumor Program. He is also an integral member of the Multidisciplinary Liver Tumor Program. As a clinical investigator, Dr. Liao develops and conducts clinical trials to evaluate new treatment strategies for liver cancer, bile duct cancers, and GI NETs, including targeted therapies and immunotherapies. Dr. Liao, thank you so much for joining us today.
Thank you so much for having me.
Yeah, we're thrilled to have you. So a question I love to have, because I feel like it humanizes doctors a little more, is to understand your personal background. So did you always want to be a doctor?
I wouldn't say so. I think I came to that decision probably around college. So, and I actually kind of knew I wanted to be an oncologist since then. And, that's because growing up, many of my family and friends have experiences with cancer. So, as a kid growing up, that always intrigued me, cancer, not just, why it happens, but how it affects people. And then in college, I studied molecular biology and genetics and learned about all of these very, very exciting new developments. So that was the time when targeted therapies were first coming out. I remember, really, really revolutionized cancer care at that time. So I got really, really excited about the science behind cancer. And then, moving on to medical school and beyond, I realized that as a medical oncologist, you really have a very special connection with your patients.
Mhm.
For some reason, having cancer kind of becomes part of the patient's identity, and then they see you as their doctor, even though they may have other doctors involved in their care, but they see you as the doctor. And that's really a very special and unique relationship that makes our job very rewarding. So I think for, all of those reasons, this is like the perfect fit for me.
And where did you go to medical school?
So I went to Vanderbilt in Tennessee.
Nice. And when you started medical school, did you know that you wanted to go into liver cancer?
I actually didn't know. I knew I wanted to go into oncology, but I was trying to keep an open mind. I remember in medical school, working with mentors, writing trials in kidney cancer, actually, because that was when a lot of the targeted therapies were first coming out at that time. And then, moving on to residency, fellowship, working a lot actually on breast cancer research. And then, starting at the University of Chicago, I actually became a liver cancer, bile cancer expert. So I kind of try to keep an open mind every stage of my career, try to learn as much as possible. So
And how long ago did you join the University of Chicago?
I started in 2017.
Okay. So what was HCC like 6 years ago when you first started in this field versus where it is today? Because in some cases, 6 years is not a lot of time for anything to happen, but a lot has happened. So can you tell us about that?
Yeah, a lot has definitely changed, like when I started in 2017, in terms of systemic therapy, all we had was sorafenib. And since then, I think around like late 2017, 2018, there's just been an explosion of, phase three trials that were positive, proving that new therapies can help people live longer. And now we have many, many approved systemic therapy, as a result of these clinical trials. It's actually very rewarding for us doing clinical research, to see our trials come to fruition, translate into new options that can actually help our patients live longer, live longer and also with better quality of life. And we also are very grateful to our patients who participate, in these trials to help us advance our research.
So you're involved in research, correct?
Yeah, so I conduct clinical trials and develop clinical trials in liver cancer, bile duct cancer, and neuroendocrine tumors. So
Is there anything exciting you're doing right now in liver cancer specifically?
I think one of the challenges for liver cancer is finding out biomarkers, right?
Mm.
Are there specific um, targets, in the DNA makeup, genetic makeup of the tumors that we could target with, new drugs or new strategies. So there are many trials that are investigating, what are some novel targets in liver cancer.
Wow. The whole theme of this workshop is your multidisciplinary team. So, what is your definition of a multidisciplinary team, and what does that actually look like in practice where you are at the University of Chicago?
Yeah, so I think it's very important, when we take care of our liver cancer patients, we really need many different specialists involved. So not just the oncologist, but we need a hepatologist because actually most of our liver cancer patients have underlying liver disease, and their longevity, their um, how well they do is actually not just dependent on how the cancer is doing, but also what the underlying liver disease is doing. So we need
Right.
to partner with our liver doctor, hepatologist, to help kind of co-manage underlying liver disease. And many of our patients, with earlier stage disease are eligible for surgical resection or transplant. So then a surgeon definitely has a huge role in this. And then we have treatments that target the liver directly, these liver-directed therapies like embolization, ablation, and that's done by interventional radiology. So it's very important to have this collaboration. And finally, making the diagnosis and assessing response in liver cancer is very challenging. There's a lot of nuances in interpreting the scans, and so we need a very experienced diagnostic radiologist as well. So at U Chicago, we actually have, a program of all of these specialists. We actually have a clinic where we physically see patients together. So like, me in oncology, I'll walk in with my colleagues in hepatology and surgery and IA. We all actually go in together to the room to talk to the patient, and patients love it because like one-stop shopping. They're hearing like a unified message. It
So they see
avoids a lot of the
everybody on the same
exactly.
day?
Yeah, they see everyone on the same day.
Wow.
Monday afternoons is our clinic, and usually we review their cases the Thursday before where we have our tumor boards. That way, when we walk in, we already have a plan. So it cuts back on a lot of the back and forth. I think it's a very good, it's a great way to do it. So we're lucky to have our colleagues at University of Chicago, partnering with us with this multidisciplinary liver tumor program.
Wow. HCC has become so complex. I mean, it's a complex disease already, like you mentioned, because there's usually underlying liver disease, but there's just so many options. So how do you decide which therapy to start a patient on?
Yeah, so as people know, there are two first line, or there's multiple first line therapies that are approved in terms of systemic therapy. And from my personal practice, I kind of try to think of what the patient is a better fit for in terms of, one versus the other. So, for example, what other medical conditions do they have? Do they have bleeding risk? Do they have a
Mm.
lot of uncontrolled heart issues or high blood pressure that might not make them a good candidate or a good fit for treatments that, target the vascular endothelial growth factor pathway that may increase the risk of bleeding and things like that.
So, what percentage, you mentioned the underlying liver disease again, what percentage of your patients knew something was going on with their liver? If they had underlying liver disease, like what percentage actually knew ahead of time?
Yeah, I would say probably like 60% of patients knew there was something going with the liver, or there is cirrhosis or fatty liver. Um, and then there are other patients who are who find out that they had underlying liver disease when they are diagnosed with liver cancer.
And what is the most common at the University of Chicago with your patients, the most common underlying liver disease that you're seeing today?
So we're seeing a lot of more patients with fatty liver disease, So I think that's probably one of the most common underlying etiologies or liver disease that we see in our liver cancer patients.
And that's a change, right, from before? That
Yeah, definitely. And we don't understand why. And, it's definitely an area of much needed research to understand, like, not just why it's happening but more importantly, how we can prevent it, either with either lifestyle changes or medications like chemo prevention. And the other part is like how to, educate, right, the public and public health efforts to make this like a prevention effort.
So I want to stay with that for just a second. So can fatty liver, I know that's not your particular area of expertise, but you know, can, you talked about future research. Can it be managed with lifestyle changes? Is that enough? Or do some patients need more?
Yeah, so lifestyle changes is a big deal. So that includes changes in diet and their exercise habits, avoiding alcohol, things like that. Um, but also there's some data for, things that can reduce liver cancer risk. Like there's some, data on, coffee consumption and medications like aspirin and things like that. But, nothing like high level data yet, so that it hasn't made into a uniform guideline, hasn't been made into a uniform guideline that people need to, take this medication and such. So I think that's an area of active research. Maybe in the future we'll have some more effective preventative strategies or management strategies. And Chicago, we actually have a dedicated fatty liver clinic run by our hepatologists. So they're working a lot
Wow.
on this. So
Is Dr. Pillai part of that?
yeah, Dr. Pillai and her colleagues. Yeah.
Yeah, and so for the people who didn't see it in April, we had a workshop with the liver disease doctors, and Dr. Pillai was one of our panelists. So be sure to check that out. If you follow us on Crowdcast, you can get a link to that event. What do you think are the biggest challenges for HCC patients today? What are you seeing with those
Yeah.
patients that come to you?
I think one of the challenges is kind of navigating the complex landscape because there are so many different specialists involved, and we're blessed in our academic center where everyone's accessible, but in the community it may not be that way, and we see patients kind of getting bounced around, and or maybe patients could have been potential candidates for curative treatments, but maybe they got referred to an oncologist first, and the oncologist may not be as aware of, what are the criteria to consider patients for transplant and things like that, right? Um, so I think that's one of the main challenges, navigating the care in this complex landscape, and the landscape is um, has really changed a lot since I started, many years ago, and I think it's become definitely increasingly complex. So.
And one last question. What kind of support services are there for HCC patients, specifically at the University of Chicago?
Yeah, so in addition to meeting the specialists, I think some of the um, other uh, providers that are very very influential in taking care of our patients with liver cancer. One is our palliative care colleagues. They help
Mm.
us with pain and symptom management. I think that's so crucial to any cancer patient's care, including liver cancer patients. We have dietitians, we have dedicated cancer psychologists and psychiatrists to take care of our patients' mental health. And then, social workers to help with patients whose care is affected by, social determinants of health. So,
Yeah, I'm glad you mentioned palliative care. That's going to be the focus of one of our workshops in the fall. So thank you so much for mentioning that. All right, Dr. Liao, we're going to have you stand by. As a reminder to everyone, we will have a live Q&A at the top of the hour. And so please put your questions in there. So we're going to say goodbye to Dr. Liao for now, but he will be back. Thank you so
thank you.
much. And we're going to welcome Dr. Pasche to the stage. And while we're waiting for Dr. Pasche, again, just a reminder, if you have any questions, put them in the Ask a Question, and you can upvote other people's questions, and we will get to them at the top of the hour. And let's see, Dr. Pasche is joining me, so let me tell you a little bit about him. As director of the Comprehensive Cancer Center of Wake Forest Baptist Health, Dr. Pasche holds the Charles L. Spur Endowed Chair in Cancer Research and is chair of the Department of Cancer Biology. Dr. Pasche was the founder of the Cancer Genetics Program at Northwestern, was the chief of Division of Hematology and Oncology and deputy director at the University of Alabama at Birmingham Comprehensive Cancer Center. His research is focused on cancer susceptibility and new therapies for cancer, and Dr. Pasche has developed a new medical device for the treatment of HCC, which received European regulatory approval in 2018. Since joining Wake Forest in March of 2014, Dr. Pasche has led a major expansion of the Comprehensive Cancer Center and the Department of Cancer Biology, which has resulted in a near doubling of NCI funding between 2014 and 2018. Dr. Pasche, thank you so much for joining us.
Thank you very much, Adrienne. Just a brief correction. I am no longer the director of the Cancer Center and Cancer Biology Chair since last year, but everything else you stated is correct.
Oh, okay. Thank you for that. Well, I'd love to start with this question again, just to humanize doctors a little more. Did you always want to be a doctor?
No, I don't think so. It was more of a choice of exclusion when I finished my high school in Switzerland, where we need to decide which way to go. Either engineering, which was interesting to me, law, that was also interesting to me, or medicine. And after carefully looking at the different options, I decided that medicine was the most attractive, but not always. And after a few years medical school, I decided this was indeed the right choice, and always stayed in the field.
Wow. When you started medical school, did you know that you wanted to go into liver cancer?
No, I did not. I think I was traumatized by the death of my brother of acute myeloid leukemia when he was 21, and I was 23. At that time, I was a medical student still, and felt rather that I would not go into cancer because it was too painful for me to relive the experience of my brother. And that's changed when I was a resident or an intern at New York Hospital, where I did my residency, and rotated through Sloan Kettering, and became exposed to the leukemia ward. And I saw many young people dying of leukemia. And one morning I decided that this was really something that grabbed me so profoundly that I felt that I wanted to move in that direction. And since then, I've only been focused on cancer. Liver cancer became more of a subspecialization during my training at Sloan Kettering. I started to enjoy working with GI malignancies, and worked both on colon cancer, liver cancer, pancreatic cancer, and subsequently had really stayed focused in gastrointestinal malignancies, a bit like Dr. Liao. And then started this project on the development of novel technology for the treatment of cancer back in the early 2000s, and which has culminated into the development of this device and its application for liver cancer.
Wow. Oh my goodness. Who was your very first HCC patient?
First HCC patient I remember very vividly, a young African man that came from West Africa that was probably in his early 20s. And I saw him in clinic with my attending at that time, Dr. Saltz. And he explained to me that because the liver function was so poor, we were very limited in anything we could do. And that was the first realization of how dire the disease was at that time. It was in the 90s when it was picked up at a late stage where patients were already jaundiced and had very few options. So that's my first vivid memory. I had another one during my medical school at Karolinska Institute, also a young man, probably in his 40s, that was diagnosed with liver cancer, also at a very late stage. And there were no options for these two patients. I remember wondering, why don't we have better option while we have so many other options for other cancers?
Yeah, so 40s and 20s is still very young for HCC. So did those two patients who really stick out to you, did they have underlying liver disease?
The patient from Africa, I remember, had chronic hepatitis, and I do not remember if it was B or C, but had a history of hepatitis and chronic liver disease. The patient in Sweden, I do not remember. It's a very long time ago, and I do not remember.
That's fair enough. For you, what you're looking at today, especially given that you've developed this medical device, what was HCC like 10 years ago versus today?
I think 10 years ago, we had only one option, which was sorafenib, as Dr. Liao pointed out. Today, we have more options. Checkpoint inhibitor, also called immunotherapy, have certainly made a major inroads. And we have more options for patients with liver cancer. I think with the changing pattern of liver cancer, we see more patients at an early stage. So they have more option, both in terms of localized therapy as well as systemic therapy. I think we're better also at assessing the patient that may be best qualified or eligible for liver transplantation, which remains the best long-term therapy if available. So things have changed quite a lot in the past 10 years. I would say it's a nice progress, like what we observed with colon cancer about 20 years ago, but we're still far from where we would like to be, which is keeping patients alive for many, many years without adverse events.
Yeah. So what efforts do you think we could make in the US to improve screening for HCC?
So I think in the US, we know that we have some population that are at risk, patients in certain part of the country. For example, Texas, we have some ethnic group, Hispanic American in that region, seem to have a particularly high rate of liver cancer. Asians with chronic hepatitis are also at high risk of liver cancer, and patients with obesity and diabetes are also a group that is emerging as a high risk group, in addition to the risks we know, chronic alcoholism and other liver diseases. So I think what we can do is to move in the direction where we have gone for breast cancer, for colon cancer, trying to identify the patients at risk and start to improve our modalities for early detection, since we know that the outcome of patients with early stage hepatocellular carcinoma is much better than those who are picked up at a later stage.
Yeah, I totally agree. What do you think are some of the biggest challenges for these patients?
For patient with a diagnosis of liver cancer or for patient at risk of liver cancer?
Let's say patients with a diagnosis of liver cancer. Good
Patient with a
distinction.
diagnosis of liver cancer, I think the major challenges are the therapeutic options at an early stage. They have chemoembolization, they have a radiofrequency ablation, they may have resection of the disease, and they have liver transplantation. So I think patients may not always be in parts of the country where all these options are available.
Mm.
And the multidisciplinary management of liver cancer probably provides the best outcome when all these modalities are offered at an early stage, so that patient can really select what will fit their best quality of life and long-term goals. The emergence of more centers specialized in liver cancer, I think, is a good start. But this multidisciplinary offering in early liver cancer treatment is crucial to improve outcome.
Yeah, my goodness. The theme of this workshop and the subsequent one, the one last month, is a multidisciplinary team. So, what is your definition of multidisciplinary team, and what does that actually look like at Wake Forest?
It looks it looks very much like what Dr. Liao was describing at the University of Chicago, and I think that's what you're going to find at most comprehensive cancer centers. We discussed most cases, if not all of them, with gastroenterologists who are specialized in liver disease, called hepatologists, surgeons, radiation oncologists that may provide various treatment, chemoembolization, TheraSphere, radioactive beads, and obviously medical oncologists that provide the options for systemic treatments. We have also a fairly large array of clinical trials, which are always the next step towards better therapies. And we try to screen patients for these various options at an early stage and discuss them as a group based on the finding of the clinician with respect to the functional status of patient, called the performance status, based on the liver function, based on the preferences of the individuals. So I think my experience with multidisciplinary team is that this is the best way to treat patient and to provide them with a comprehensive array of options at the various stages of the disease.
You said something just now about assessing them and screening. How does that look in practice, in reality? What does that actually look like?
Well, assessing the functionality of the patient is to ask how much or what can they do. If a patient is bedbound, is very limited in their physical activities, we know that the likelihood of them responding well to therapy and of a good outcome is much lower than patients that are very vital, that are barely affected by their diagnosis, are able to walk around and are physically active. That's called the performance status. And that needs to be assessed by the physicians because it will have an impact on the treatment options that can be offered to these patients.
Got it. Okay. And one last question before we welcome Dr. Abou-Alfa to the stage. How much of your time now do you spend doing research versus seeing patients? Because I know you do both.
Yeah, I would say approximately 80% research and 20% clinical activity.
Nice. And do you have a clinic day like
I
University of
do. It's
Chicago?
Thursday, every Thursday. Yeah.
Every Thursday. I love it. Okay. All right, Dr. Pasche, thank you so much. So stick around for the Q&A at the top of the hour. I'm going to put you back in the audience for now.
Thank you.
And we're going to welcome Dr. Ghassan Abou-Alfa to the stage. And while we're doing that, just a reminder to put your questions in the Ask a Question and to upvote the questions. So I see all the questions have one vote. If there's one that really stands out to you, please put it in the questions, which we will be doing at the top of the hour. Dr. Ghassan Abou-Alfa is an associate professor at the gastrointestinal oncology service at Memorial Sloan Kettering Cancer Center and Cornell Medical College in New York. Dr. Abou-Alfa specializes in the treatment of gastrointestinal malignancies, and in particular, hepatocellular carcinoma and biliary cancers. Dr. Abou-Alfa serves as the chair of the National Cancer Institute Task Force for Hepatobiliary Cancers, the chair of the AIDS Malignancy Consortium, and Non-AIDS Defining Malignancies Liver GI Task Force. Dr. Abou-Alfa has lectured worldwide on the subject of gastrointestinal malignancies, and he is a strong advocate for raising awareness and support for improving the outcomes of patients with this disease, as well as enhancing oncologic education worldwide. Dr. Abou-Alfa, thank you so much for joining us.
Thanks so much, Andrea. Great seeing you, and it's a great honor and delight.
Great to have you.
I would like to point out here, just in the many titles, that's very humbling and honoring that you brought up. I'm the previous immediate chair of the NCI Task Force for Hepatobiliary Cancers, and at the same time, I'm the vice chair for the AIDS-defining malignancies and non-AIDS-defining malignancy for solid tumor working, which include liver cancer.
Thank you so much for that correction. I appreciate it. And I also want to point out that we did mention your bio, but you are chair of our medical advisory board here at Blue Ferry. So thank you so much for that. Going to start with a question I love to ask. Did you always want to be a doctor?
Not sure. If anything, the background is like, you go to school, you do hard work, and you ultimately you go to college, and in college, really, frankly, things start defaulting in one way or the other. But the reason I say that is because even though I did not ever say I want to be a doctor, but I think the mindset of a physician was always in me, which mainly the key element of it is helping people. So I, for example, like at age 10 already, I was volunteering in the Red Cross. So that's
Wow.
really already can tell you where things were going.
Nice. Okay. And I hear an accent. So would you mind telling people where you're from?
I'm from Lebanon, and I graduated from the American University of Beirut. Uh, and after that, I went to Yale, where I did all of my training. I was at the faculty at Yale. And then from there, I moved to Memorial Sloan Kettering, where I have been for the last 23 years.
Wow. And when you started medical school, did you know that you wanted to go into liver cancer?
No. Interestingly enough, that did not come till later on. I was intrigued, no question, especially when I was at Yale and having in the middle of the night the patients who really are between life and death, and they're waiting for a transplant, and then a transplant shows up because of somebody who's really donating their liver. This really the complexity of the extent of the situation is, but at the same time, the great positive that brings up with it. But I say it a little bit reflectively and jokingly because this is really tells us how life can take us in different routes. When I was accepted at Sloan Kettering for the job, I received an email, and believe it or not, yes, there was email 23 years ago. And at that time, my chief, Dr. David Carlson, said, "Would you like to do gastric cancer or liver cancer?" And I thought about it, reflected on it. I took my time. This was Monday. I did not answer till Thursday. And I said, "Yeah, I would
Really?
like to do gastric cancer." After all, it's very common. It's all over the world. There's a lot going on, etc. And at that time, sadly, not much was going on in liver.
Right.
And he emailed back and said, "Well, sorry, but the other colleague that we brought in on board, who is a very dear colleague now, the head of GI at Cornell, Dr. Manisha, elected to go with gastric cancer. So you'll do liver cancer." And I say that maybe some of you have heard it before, and I say it always because to tell always our young colleagues, take your time. Don't just like text respond, click email right away. Reflect on your answers, and that's probably the best reflection I've ever had, because coming to liver cancer was really a incredible eye opening. Sadly, in the beginning, not much was going on
Right.
because we didn't have disease management that's delineated by any systemic therapy. And truly, and sadly, the best we could offer is to patients go home. And I'm really beyond gratified and humbled and honored that I was the first to give sorafenib for the first patient with liver cancer, and this really made a big difference. So it's kind of like to live the disease from really from point zero, from day one till today, was really an incredible eye opener to how much really we are in need for helping patients the best way we can.
Let's talk a little bit about that. So sorafenib came along and established a new standard of care for a really long time. What has been the most challenging in this sort of, now we're going into a post-sorafenib era?
So, no question, sorafenib came a little bit by reflection and default, but understandably, the phase one showed some potential benefit per se.
Right.
And at the time, interestingly, what we understood or probably misunderstood about sorafenib was not necessarily really why we used it for liver cancer. Later on, we discovered more about its super values in regard to tyrosine kinase inhibition, which, by the way, for our great audience, tyrosine kinase inhibition is like literally inhibition of certain enzymes that really are responsible for replication of cells. That's really what it is. And interestingly, you don't want like a pure kind of like weapon. You want like a dirty weapon that really can take care of things in different direction, because it's not only one pathway that really grows cancers, many pathways or many tracks per se. And so that's really the beauty or the benefit of sorafenib per se. I have to say that sorafenib came on is a great delight. It was really touching to see how many patients can really do better, and how long they are really living compared to not really living long beforehand. And from that point on, the challenge was really kind of well delineated. 2 points is number one, can we improve on the outcome of sorafenib? And number two is, can we make sure that patients will be able to tolerate the therapy very well because of the adverse events or what we call side effects?
Right.
And to be fair, later on, which I'm sure we're going to talk about, like another third reflection is, how can we make sure people are getting really the treatment wherever they are in the world for sorafenib?
Right. Right. That's really challenging. Um, let's talk a little bit about your work at Sloan. The theme of this workshop, as I said, is about multidisciplinary team. What is your definition of a multidisciplinary team, and what does that look like in practice at Sloan?
Yeah. So, and forgive me, I'm not trying to correct you, but we like to make sure we give credit to Mr. Kettering as well. So it's called no more Sloan Kettering.
I apologize. Sloan.
Two incredible, really development minds from the car industry who really built in Sloan Kettering.
Right.
Even though beforehand the story evolved through many of the well-known families of New York, among which the Rockefellers and the Astors and ended up with Sloan Kettering. So it was really a surgical project because this is really what we used to do for liver cancer and for
Right.
any cancer is to cut it out. And then it evolved in the different directions where we stand it. Now, interestingly, and some people might not know that, actually the whole idea of multidisciplinary team started at Sloan Kettering.
Really?
So,
Oh, I don't think I knew that.
so,
Tell
so,
us
so, if
more.
anything, the first time the perspective that we are all oncologists in a horizontal, or you want to call it horizontal line, like in other words, we really talk to each other as medical oncologists. We are actually at Memorial also we are divided into a vertical line, where in
Okay.
other words, the surgeon, the hepatologist, the gastroenterologist, the medical oncologist, add on the interventional radiologist, add on the radiation oncologist, who really have an interest and they really are involved in regard to liver cancer, they connect together. This was really all the way back, believe it from the 60s. And we call it actually a disease management team, DMT, which later on became a multidisciplinary team in other subjects per se. And believe it or not, historically, this meeting has been happening for the last, wow, you can count with me here, but like about 60 something years, every Thursday. And what
Wow.
we do is we spend an hour, talk about the research. For example, I have a new project. I don't come to speak about the project that I have as a new study just whenever it's ready. Believe it or not, the same way the medical oncologist will review and decide this is a good study to have, the surgeons have a say, the hepatologists have a say, so we're all on the same page. So we spend the first hour about discussing new project, new idea, new concept, and everybody has a say, and it will be reviewed officially with the different group team of the disease management team. And then the second hour, which really I say it's an hour, but can end up like with 2 hours, 2 hours and a half, we discuss the patients.
Wow.
And interestingly, something that really quite fascinating at Memorial, and not, but it's appropriate how it's done in everywhere else, where you submit which case you want to present. The radiologist can review the case in advance. They are ready to come and present it per se. Believe it or not, that memo is all live. In other words, I can show up to me and say, hey, by the way, I have a case. The radiologist could have never seen that case. The pathologist could have ever heard of that case.
Right.
And usually maybe did not even have a chit chat about it beforehand. And believe it or not, I present the case and all other colleagues are like live, just giving their input right on the spot. It's not like they're prepared with their answers. So this is really how amazing and engaging it is every week for that purpose.
Wow, that's really cool. You mentioned research. So how much time do you spend doing research versus seeing patients in clinic?
I spend 100% and 100% of each. Well, I don't think really, by definition, our job is a 100% academic job where it's called the 40-60 formula, where you spend 2 days in clinic
Hmm.
and 3 days in research. But admittedly, I say 100 because your mindset cannot stop like here doing this versus doing that. Because, for example, if a patient is in need on a day which is not clinic day, you're not going to say, oh, sorry, today I'm doing research. We're heavily involved in regard to the care for the patient, especially liver cancer patients. They really need a lot of kind of help and support all the time. And on the other hand, in regard to the research, your ideas are evolving with time because remember we have clinical trials. You are involved in regard to the process in the clinic per se. So I think your mind it kind of like becomes geared, and you are thinking about both literally unconsciously all the time.
All the time.
Yeah.
Wow. You mentioned resources. So what resources does Memorial Sloan Kettering have for HCC patients specifically?
We're very grateful to be at a very thoughtful and generous institution. And if anything, number one, the leadership really has been uh, incredibly supportive of all the efforts that we have done. We have an incredible CEO who really has a vision which is really very broad and robust and upbuilt, Dr. Vickers. And Dr. Selwyn Vickers' perspective is like really to have Memorial like really at the center stage for cancer care anywhere in the world. And because for us, it's not really just being there. In other words, we have to welcome people to memorial to be taken care of. That's not the point. For us is if a patient gets the access and the right access to therapy, wherever they are, and if we did help contribute to that ourselves, we're comfortable. This is really what we are for. We're not here to really have the business part of it, like, okay, patients are being taken care of by more. It's not the point. Add to this, the resources are kind of, multi-directional, but the ones that at least are pertinent in regard to the liver cancer care. I have to say we have a incredible team of highly advanced nursing skills nurses who really and at their helm is a superb PhD nurse who really kind of making sure that patients come first and then at the same time engage as a teamwork. It's not like them and us. It's really a teamwork. For example, our research teams, our research meetings, our review of the clinic, our debriefing on studies, our new publications, all shared between all of us. And we
Oh,
hear
that's
it from nurse
fantastic.
perspective, we hear it from the medical doctor's perspective.
That's
The
fantastic.
third thing is, I agree, and this is really what's really give a lot of comfort in that regard. And the third thing is, of course, a very robust administrative team. I mean, it's incredible when your administrative team really is thinking along with you. We have the following patient coming. What shall we do? Or you notice, for example, that the patient missed that CAT scan. What shall we do
Mm,
to make up for it,
right.
etc. We come to clinic like really to surprise ourselves, like, okay, what shall we do today? We come to execute. The planning already is done. The kind of strategy of the specific clinic is already set, and simply we just come to do the performance. That's really what we do in clinic. Of course, surprises can happen, but nonetheless, pretty much almost always things already are set regard, and this could be nothing but more to the theme. And then after that, we have a research team. This is a very, very strong team that really branches in different directions. We have different directors, and they really are in charge with their team about every clinical trial that we have. We meet literally with the directorship weekly. We
That's
meet with
great.
the whole research team also weekly, and we review patient by patient. Every patient was there on in regard to clinical trial. Literally, we just like go over details of the details. And what I love about it is that it's not like the attending physician like myself or any of my colleagues come and say, "Hey, by the way, what about this patient?" No, we let them try it, and
Mm,
this is really because you want to make sure everybody's engaged. So actually, the research manager who really is in charge of a specific study will say, "By the way, my updated situation regard to patient X, patient Y, patient Z is 1, 2, 3, 4 details." So they really get the buy-in. They really are responsible, same way we are. And this is really what kind of bring it is a multidisciplinary team per se. And of
wow.
course, finally, is my dear colleagues. I mean, this is a teamwork. And this is really where I go back to the multidisciplinary team. Uh, Surgeons, hepatologists, gastroenterologists, interventional radiologists, pathologists, radiation oncologists, and my other dear colleague in medical oncology who really we work the things same together. Again, we spend a lot of time together to really vet out, and most importantly, we're always readily available for each other. That's really what makes it a great success.
Wow. Thank you so much for that insight. I want you to stick around. We're going to put you back in the audience for just a moment and then bring you back for the Q&A at the top of the hour.
Sure.
So thank you so much, Dr. Abou-Alfa.
Thank you.
And we're going to welcome Dr. Mark Yarchoan to the panel, to the stage, if you will. Thank you so much for your questions. We see them. We are going to answer them. Dr. Mark Yarchoan is an oncologist in Baltimore, caring for patients with gastrointestinal cancers. His clinical focus is on the cancers of the liver, including hepatocellular carcinoma and biliary tract cancer, meaning cholangiocarcinoma. Dr. Yarchoan received his undergraduate degree in neuroscience from Amherst College and earned his MD from Perelman School of Medicine at the University of Pennsylvania. He completed his residency in internal medicine at the Hospital of the University of Pennsylvania and performed a fellowship in medical oncology at Johns Hopkins University School of Medicine. Dr. Yarchoan joined the Johns Hopkins faculty in 2018. He directs a National Cancer Institute-funded laboratory focused on the discovery of novel cancer immunotherapies for hepatobiliary cancers. He also co-leads the Liver Cancer Multidisciplinary Clinic. Dr. Yarchoan, thank you so much for coming on.
Thank you for having me.
Yes. So I'm going to ask you the question I've asked every doctor so far. Did you always want to be a doctor?
No. I come from a family of physicians, and often if you're born into a family that does something, you want to do something different. So I grew up thinking I actually would not be a physician. But I had a love for the sciences and desire to help people. And, slowly I came back to realize this was probably the best path for me.
Got it. How did you end up in medical oncology?
So when I was doing my residency at Penn, I was there at a time when there was an amazing amount of progress in cancer that was actually happening at Penn at the time. So I was there when the very first patients were being treated with CAR T cells.
Wow.
And these were patients who, many of them had really truly run out of options, had been told that they, should pursue hospice care, or enroll potentially in this totally experimental therapy. And, I was on the wards caring for these patients, getting these new therapies, and some of them did amazingly well. And a number of these patients, I still remember vividly. And it just seemed like a place where a lot was changing. New therapies were going directly into patients. And as someone who not only enjoyed caring for patients, but also was interested in research, it seemed like the rare place where I could really translate and really make a difference in patients' lives.
What does your patient population look like there in Baltimore?
It's a great question. We have an interesting patient population here. Baltimore has an incredibly high incidence of hepatocellular carcinoma because a lot of the risk factors for HCC, viral hepatitis, and obesity are incredibly common here. And I would say that many of our patients from Baltimore are sort of traditionally underserved populations. I see, as you can imagine, a lot of patients who are homeless, have active substance abuse problems, et cetera. But then we're also Johns Hopkins. So as you can imagine, patients often travel here from far away for an opinion at this institution. So it's not uncommon for me to have days where I'm seeing patients who really struggle to even afford their basic medications, followed by patients who took a private jet to come here to see us.
My goodness.
It's an extremely diverse population that I see. And I see, I would say, both ends of the wealth spectrum and et cetera.
Is there, while we're talking about patients, is there a particular patient who sticks out to you? And if so, why?
There are many, as you can imagine. I'll never forget the first patient I ever treated with HCC who had an amazing response to immunotherapy. At the time, immunotherapy was not approved. This was on a clinical trial, and the patient had really a complete response to anti-PD-1 immunotherapy and had all of their lesions completely melt away.
Wow.
I have to say, I hope for this every single time. I don't see this very often, but seeing it once at a time when all we had for HCC was sorafenib, I really felt like things were about to change, and that's a large part of why I decided to go into treating liver cancer. I have to say I'm obviously a little bit more junior than, for example, the last speaker, Ghassan Abou-Alfa, and I have tremendous admiration for people who went into this field when we really had nothing.
Yeah.
And as a large part due to all the amazing research that Ghassan and others did, we now have this whole array of different treatments, and it's really made a difference not only for patients but also for the providers, because I think we have a lot more hope to offer our patients.
Yeah. What are the biggest challenges that you're seeing in your HCC patients?
Well, I mean, one challenge that's, I think, pretty obvious is that, I mean, even though we've made amazing advancements, we have a long ways to go, even with our most contemporary immunotherapy doublets. Patients getting standard systemic therapy now, only a third of them or fewer have true responses where their cancer shrinks. So despite all the amazing progress that we've talked about, a third is not 100%. It's not even a majority, and I'm hopeful that the rate of progress will continue. It needs to.
Are your patients presenting with any sort of symptoms or signs?
Patients presenting, like, how do my standard patients present? Is that?
Yeah, are they having any sort of common symptoms across the board?
Yeah, I mean, some patients who have known cirrhosis are in screening programs, and those tend to be the patients who have their cancer detected at an earlier stage and can come in for consideration of potentially curative therapies. In general, though, many patients who develop HCC don't even know that they have cirrhosis, don't even know that they have risk factors for it. They tend to present at an advanced stage. And the symptoms are pretty non-specific, unfortunately. Patients who present with pain, with jaundice, they turn yellow if their liver is not working as well due to tumor. Patients can have all sorts of non-specific complaints, fatigue, etc. And more, patients are coming in and getting scans for other reasons and incidentally found to have liver masses. That's another large group of patients that I see.
It happens so often. It's so interesting. So the theme of this workshop is your multidisciplinary team. And so can you tell us, what does that mean to you? And what does it look like in practice at Johns Hopkins?
Yeah, so the multidisciplinary team is incredibly important to us at Hopkins. We actually feel that every single liver cancer patient should be evaluated by our multidisciplinary team, and that's because first of all, most patients with HCC also have underlying cirrhosis. About 90% of them do, and we believe that patients should be co-managed with hepatology. And the multidisciplinary team is a way that patients come in and see both of us. Before we had a multidisciplinary team, patients would often have 4 different appointments. They'd go see surgery, they'd go see interventional radiology, they'd come see medical oncology, they'd go see hepatology, and then there'd be emails going back and forth between all of us. Now patients come in, they see all of us all at once, sometimes in the same room. We review the scans together, we present a unified plan. I think it makes the patient experience better, but there's also now data that doing this can actually improve outcomes. So we feel very strongly that all patients should seek a multidisciplinary evaluation.
I love that. It's not always possible, right? For some patients. With the patients you're seeing, are you seeing a difference in the base cause for HCC?
Well, there's certainly data that more and more HCC is associated with NASH or NAFLD, so obesity. As we do a better job treating hepatitis B and C, viral hepatitis, the data suggests this is a decreasing cause of HCC in the West. Certainly my anecdotal experience suggests that this is the case, but there's real data for this now.
Wow. Do you, the decrease in hepatitis C, do you think that's because of the number of curative drugs on the market?
Yeah, I mean, there is this misconception that patients have where, they have viral hepatitis C, they get treatment with Harvoni or one of the new anti-hep C drugs, and then they really tend to think that they're out of the woods for HCC. We've heard this many times from patients.
Yeah.
But unfortunately, there is this continued risk for HCC even after hepatitis C has been treated. So the risk does go down. There is a benefit of decreased HCC. So if patients have hepatitis C, they should get treated, obviously. But I would just encourage, if there happen to be people on here who have hepatitis C, who don't have HCC, these patients should continue to get regular screening.
I'm so glad you mentioned that. I can't count the number of people in Blue Fairies community specifically who had hepatitis C, had that treated, and were never told that they needed to, be screened.
Absolutely.
For the rest of their lives, and ended up developing HCC. So I appreciate you saying that.
The other thing that I'm seeing more and more of, and I'm actually interested to hear from my co-presenters if they're seeing the same thing, are more and more young people who have really no risk factors, no cirrhosis, who are coming to see me with HCC. And I've heard this anecdotally from many of my colleagues. I don't know if my friends are seeing the same thing here.
Well, we'll have to find out. So on that note, we are going to invite them to the stage. So please stand by. I see all of your questions. Dr. Yarchoan, you're not going anywhere. So
okay.
All right, hang in there. You will stay put. Let's see, bringing Dr. Pasche back to the stage. Dr. Abou-Alfa back to the stage. And hold on just a moment. Looking for Dr. Liao. There he is. Let's bring him back to the stage. Okay, so we have a lot of questions here. It is time for our Q&A. So please, if you have asked a question, please put it, if you've asked in the chat, put it in the Q&A, and please vote these questions up. And so we're going to start with this very first one, and anyone can answer, guys. So what are the current guidelines for monitoring those with liver disease at risk for HCC, including lab and diagnostic testing and frequency it should be done? Anyone want to take that? Oh, I'm going to pick on someone. Okay, Dr. Abou-Alfa?
Thank you so much, Andrea. So all what you mentioned is absolutely correct, and it's really a lot of factors that play a role. But I would say the most important, and really we need to stress this out, is the patient themselves. We have to look at the patients. It's incredible how much, and especially now in the new era of telehealth and phone calls or what have we, seeing the patient, looking at the patient in the face, and look at them in the eyes, and at the same time examining patients make a big difference. I would say that a physical exam for patients with liver cancer is probably half of it is done the minute you open the door of the room and you just look at the patients, because you have a general sense about their well-being. Number two is you can see if there's a assessment of the cirrhosis component that can play a role in regard to liver cancer. Are the eyes yellow? Is there itching? Are they blistering? Is there ascites, collection of fluid in the abdomen? Are the legs swollen, edema? Are they really totally withered in regard to every detail, or they might miss on certain details, which implies encephalopathy? It's incredible how much you can do just like by really engaging with the patients. And of course,
are there, though, I think what this person is asking, though, are there guidelines in place right now for all of you as medical oncologists that help you monitor that liver disease?
Yeah, this is what I'm coming to. And that's why I want to stress that point. Along that line, the guidelines are truly nothing more than metrics that will add on to that assessment. And interestingly, there's no specific guideline that say you have to do this or that. If anything, it's really become a little bit more of a routine that we depend on, among which, for example, maybe imaging on the average with somebody under care probably every 2 months, somebody with follow-up every 3 months, and maybe blood work probably within the same period. Somebody who's on active therapy, the probably assessment with blood work will be happening every treatment per se. But again, to be clear, this is really differs quite a bit on patients on active therapy. In regard to patients on screening, I would say that in general, what the guidelines say is like, at least an alpha-fetoprotein and at the same time an ultrasound once a year. Maybe some of them will say maybe alpha-fetoprotein twice a year and one ultrasound once per year. But again, sadly, the big problem that we have in regard to this is that patients fall off the screening, as you already yourself referred to, rather more often than not, which we don't like.
Right. Dr. Liao, any thoughts to finish out that
Yeah.
question?
So what our hepatologist colleagues go by,
What are just current guidelines? Correct.
Yeah, so there's the AASLD guideline. So basically anyone at risk for HCC. So anyone with cirrhosis for any reason, viral hepatitis, alcoholic, or fatty liver. So anyone with cirrhosis need to undergo screening, and hepatitis B patients who do not have cirrhosis, they need screening as well. And typically it's like Dr. Abou-Alfa said, ultrasound and AAP every 6 months.
Thank you so much. And I see Dr. Yarchoan has figured out how to answer the comment directly, which you are more than welcome to do. Thank you so much. All right, the next question here.
I'll just mention one other quick thing. So I was on these new AASLD guidelines that were just published this month. So I encourage people to take a look. There's pretty straightforward tables. We did put in the guidelines that we don't recommend CT or MRI for screening. But there is data that contrast-enhanced MRIs may be okay, and especially in the United States, where actually there seems to be more comfort with MRI than ultrasound, it is a reasonable alternative to ultrasound.
Thank you. Thank you so much. So the next question from Kay, anyone can answer. Is it still true that if you have had another primary cancer before you test positive for HCC, that you cannot be listed for a transplant? Does anybody know the answer to that?
Yeah, that is correct for most transplants, Adrienne. Most transplant centers, it depends what kind of tumor. If it's a relatively benign type of skin tumor, that will not be an exclusion criteria. If you have an old early stage cancer that is not felt to have a high risk of recurrence, this is open for debate. So while in most cases a recent diagnosis of another tumor type will be an exclusion criteria, it's not an absolute exclusion criteria.
Okay. All right. Thank you so much. All right. So we have another question here. I have hepatitis B and fatty liver disease. What is next? And I'm going to guess that this person means like in terms of ongoing screening and surveillance. Who would like to take that? Anyone?
I think you need a good hepatologist. That's the key. So, definitely anyone with hepatitis B need ongoing surveillance. And fatty liver in itself, not necessarily unless there's cirrhosis, but definitely for the hepatitis B.
Okay, and so I just want to make a point to the person who asked this, whether you're here or not, on the replay, you'll see this. Just be really clear, find out if you have cirrhosis, because you didn't mention that. You have the hepatitis B and the fatty liver, but find out if you have cirrhosis. All right, next, let's see. I would appreciate hearing about any advances in treating fibrolamellar HCC. What does the panel know about that? Are you seeing any fibrolamellar HCC patients, and have there been advances in the field? And for people who are just joining or don't know, fibrolamellar HCC is a very rare type of HCC, usually affects teens or young adults, and doesn't typically have any kind of underlying liver condition, liver disease. Again, so anybody like to take that?
Yeah, thanks so much, Andrea. I will take that. It's a very dear to heart subject. And number one, before we go to that, I would like to add on to what we just mentioned about the hepatitis B for our dear, question asking person. Interestingly, hepatitis B causing liver cancer does not necessarily have to be associated with cirrhosis. And it was really, it's not a matter of like cirrhosis or not. The mere fact that there is hepatitis B is enough to be justification for doing this screening. With this said, the fibrolamellar carcinoma, I might actually differ in regard to view, and this is not only me. Actually, many of us will differ. This is not a version of hepatocellular carcinoma. Actually, it's
Right.
totally different disease. It just
Yeah.
happened to be lodging in the same neighborhood in the liver. And if anything, it's a disease that, exactly as you mentioned, Adrian, that affects young people. The median age is about like 20, and a little bit, a tad more women than men. And why does it happen? We have no clue. And at the same, how do you treat it? There's no standard of care. This is really how bad is bad.
Right.
For that purpose, there are many things going on. And proudly at Memorial Sloan Kettering, we are really heavily involved in regard to the care for patients with fibrolamellar carcinoma. Actually, we have some of the highly refined surgeons in regard to resection at early stage. And not to add to this, we have clinical trials. And the clinical trials are a little bit of a challenge. And this is really probably an important opportunity for us to really address a key note to all our audiences to see how much of a challenge it is. Imagine that you have a disease that there are only 200 patients with it worldwide a year,
Hmm.
and you want to build a drug. This is called failed business. And if anything, sadly, companies are not interested. And we do understand that we're coming from their perspective. We do respect their perspective per se. Nonetheless, I give credit for the companies that really have been rather coming out of their way and understanding that any effort they will do is going to be a benevolent uh, obligation they do towards those patients, but it's not really the business making part. And to get to that credit, we have really been engaged in many trials, uh, among which targeting certain components of a genetic change that occurs specifically in fibroma carcinoma, not 100%, but close to 100%. It's a specific fusion of two genes that can really trigger certain growth of the cancer cells. And number two is no doubt that the ceiling in immunotherapy is coming on board. And proudly, we have a clinical trial at the moment that looking into combination of two type of immunotherapies that already have been really showing incredible good results in other cancer, among which colon cancer, lung cancer, and now we're doing it in fibromyalgia carcinoma. So
Wow.
that's we're delighted at least that we have options, and it's nice to kind of like see this engagement with the pharmaceutical industry continuing to grow with different companies per se. The
Thank
other
you.
effort that we're doing is to really understand why patients get this cancer. And so we have a registry where we're trying to really understand from the norms of their lives what do really get to this liver cancer. And this is really a very novel approach how we're doing it. It's not limited to patients who really are seen as Sloan Kettering. It's open to any patient anywhere in the world. They don't need to even be at Sloan Kettering or register with Sloan Kettering. And we're doing it on a very important platform, of course, which is nothing but Google. So if anything, having a Google account, you'll get some consent form electronically, and you'll just have to answer questions. But more importantly, it's a dynamic registry. We're not really looking at things only on one specific opportunity, but we're looking at them at multiple opportunities. So patients have to answer questions on monthly basis for about a year or so to simply know what's going on. We're trying to find from their trend of life, can we tell why patients get fibromyalgia carcinoma? Because yes, we owe it to our patients with fibromyalgia carcinoma.
Thank you, Dr. Abou-Alfa. We have to keep going. I do, for the person who asked this question, Corrine, I don't know if I'm saying your name correctly. I do highly recommend the Fibrolamellar Foundation and also Dr. Sanford Simon at Rockefeller University. So please let me know if you like an introduction. This next question goes to you, Dr. Pasche, and if you could relate it back to both HCC and fibrolamellar HCC, that would be fantastic. What is the device that you developed for HCC?
So the device we developed is based on the use of low and safe level of radio frequency electromagnetic fields, in simple words, radio waves, which is delivering treatment throughout the body by means of an antenna which is placed in the mouth of the patient like a spoon, and the patient take that for 3 hours daily. We have shown that this approach is capable of blocking the growth of cancer cells or shrinking the tumor in about 50% of patients. And we have also observed very long-term responses in patients who have tumor shrinkage, which is approximately 15% of patients with good liver function. The device is fairly safe. So far, we've had patients receiving treatment for various types of tumor. One patient with thyroid cancer has been treated continuously for 16 years, so we don't see any adverse event long-term. For liver cancer, the longest survivor was 6.5 years, and we did not have any adverse events. So that's the long and the short. 2 clinical trials are currently open in the US, one for patients who have failed first line and second line, which is currently open at Wake Forest and will be open at 6 other sites very soon. And another one, which is open only at Wake Forest right now for second line, which is regorafenib, together with the device. We have another first line trial, which received a excellent score in the funding range from the NCI. That would be atezolizumab, bevacizumab plus the device versus placebo.
Oh, wow. Okay, that sounds really, really interesting. And it's Therabionics, correct? For anybody who wants
The
to.
device is Therabionic, yes, THERABIONIC, and the device received humanitarian device humanitarian use designation last year by the FDA, and is currently under review for humanitarian device exemption.
Thank you. All right, so this next one is for all of you. We'll start with Dr. Liao. How have you incorporated, or have you, integrative medicine into your care approach? Dr. Liao, would you take that first?
Yeah, as a medical oncologist, our training usually does not incorporate a lot of these integrated medicine approaches, but I believe they can definitely be complementary to the treatments we give. For instance, a lot of our patients go and get, acupuncture and things like that can really help with some of the side effects of treatment, for example.
Thank you. What about you, Dr. Yarchoan, your team at Johns Hopkins?
Yeah, I think this is something that I get asked about probably more than anything else from my patients these days.
Really? Wow. Okay.
What can we do extra?
Mm-hmm.
And it's always challenging because if we knew that things work, they would be all over the walls of our building telling everyone to do these things. But we know that there are things that can probably help. We just don't have all the data, and so I think it's challenging. I think the one thing I encourage patients to do is always tell their physicians what they are taking. A lot of these integrative approaches contain very active compounds that can interact with the sorts of medicines that we may be recommending. So it's just good to have an open dialogue with your practicing oncologist.
What about you, Dr. Abou-Alfa?
By all means, we are asked all the time. At the same time, we are heavily involved in that regard because we see it from 2 perspectives. Number one is, understandably, in the front of a very sadly tough disease still, despite all the great successes that we are all very proud of. Patients also want to see what's more. And to be fair, the what's more could be right, because we don't want to claim that we know better than certain other perspective or disciplines. So we have a very robust multidisciplinary approach, including integrative and alternative therapies, including Chinese medicine. Actually, at some point in time, we had a clinical trial on Chinese medicine, because remember, how do you make Chinese medicine become a Western medicine? Just do a clinical trial and see what it does. So that's really how open we are to those ideas. And of course, we have also the multidisciplinary approach. Other than the alternative therapies, we have also the important part, which is the supportive care therapies, because the mind state is an important component of taking care of a patient with liver cancer. And so this is the kind of value of patients that we see at Sloan Kettering, that they will get all the benefits from the different disciplines, being in regard to the direct medical care, the alternative therapy approaches, or even the supportive care therapies that they need.
Thank you. And at Wake Forest, Dr. Pasche?
What would you like to know at Wake Forest with respect to integrative medicine? So we have an integrative medicine consulting team, which which provide guidance to patients. Some patients are very interested, some patients are less, but we offer then, it's called the Patient Support Program, Cancer Patient Support Program, which offers alternative medicine, acupuncture, and other alternative approaches to all cancer patients, and they are informed about that early on during their treatment.
Nice. Thank you so much. What a great question, Kay. Thank you so much for that question. Now, our last few questions are very specific, so anybody who can answer them, and I'm going to, I'm afraid, butcher some of these names. These are both, I believe, related to what we would consider secondary liver cancer, where the cancer started in another organ and then metastasized to the liver. So a little bit different, but I know most of you see that as well. So this first one from Nancy. Can you comment about leiomyosarcoma? Don't think I said that first syllable right. Metastases to the liver. So the cancer has started as a sarcoma. It's metastasized to the liver. How maybe relate that to treatments for HCC? Anybody who wants to take that, dive in.
Yeah, thanks so much. I'll try to help with that. So these are situations that do occur. The liver can have variants of different diseases that always the struggle, is it really liver cancer or something else? Remember, it's a very big organ. It has a lot of receptors for different things and different type of cells and tissues. And we have noticed that one component which is important is to have the multidisciplinary approach for that purpose. So, for example, in that specific scenario, we will involve and engage our sarcoma team, and we'll work it together. And in general, I don't want, of course, to give any answer to a specific medical situation. We're not in consulting work. But in general, what we do is we come to some consensus in regard to how much of the really player is the liver part and how much is the sarcoma part to come to do with decision making in regard to how the care would be. But the key element in all this is definitely multidisciplinary approach, where really we are engaging as a team together to be able to get the right answer or the best answer possible.
Thank you. Anybody else want to comment on that before I close that question?
I think the liver is a very frequent site of metastasis from many other tumor types. So the liver metastasis is usually treated according to paradigm or guideline relative to the disease you treat. And that will vary a lot from one disease to the other.
Thank you.
I will just make a quick comment here that,
yeah, please.
More and more as we get better and better at controlling many different cancers, I think there's more and more of a role for going in and attacking what we call oligometastasis, so little spots of cancer that are outside of where the cancer started. And the most common place that most cancers go is the liver. So I think this is an increasing area. We actually do allow patients who have liver only or liver predominant cancer from any site to come and see our liver team. And often we can provide them with sort of local therapies that were pioneered for HCC, but may be active for other cancers as well. Approaches like Y90 or ablation or TACE.
Thank you. Thank you so much. So we have another question along those similar lines. And again, this is not HCC specific, but liver specific. What are the preferred treatments or pharmaceuticals for EHE in the liver? And for people who don't know what that means, that is epithelioid hemangioendothelioma, a rare cancer that grows from the cells that make up the blood vessels, often can occur in the liver. So any experience with that?
So I help again here, and admittedly very, very limited. And if anything, this is really more of a situation that occurred in the pediatric age group. And if anything, our involvement with our colleagues in pediatrics will help quite a bit in that regard. Again, we'll avoid to give any specific answer in that regard. But as you notice from the two answers, is multidisciplinary approach is very critical for that perspective to be able to get the answer. And in general, most of those diseases already have their own approaches decided based on the predominance component, what's really leading to the cancer per se. But to really put it within the context of what we're discussing today, can it have a liver cancer, primary liver cancer component? They can. And that's where the engagement on our part will be.
Okay. Anyone else before I close that question?
Yeah, we've definitely seen, I mean, these are very rare, like Dr. Abou-Alfa said, but we've definitely seen patients with EHE in our multidisciplinary liver tumor clinic. In those situations, they're here to consider, surgical resection or transplant or liver-directed therapy as appropriate. And, because this is a kind of sarcoma, we typically engage our sarcoma colleagues in terms of systemic therapy. And we have put them on clinical trials, like phase 1 clinical trials, and they have responded to those. So.
All right. Thank you so much. Tony, I hope that gave you some answers to your questions. We really appreciate it. And just a reminder, we have our last poll up. So how much has your knowledge about HCC providers and what they do increased? Please make sure to answer that poll. I'm glad to see so far people have learned a lot of new facts. And we have one last question for all the doctors here. We're going to start with Dr. Pasche. So one of the things I have found with HCC is that more often than not, it is terminal for people. And so how did medical school prepare you for tough conversations with patients and their families? I'll start with Dr. Pasche.
So, from my personal experience, I would say medical school did not prepare me well. I think fellowship prepared me much better. Having trained at Sloan Kettering, we had a lot of exposure in terms of palliative care, tough discussion with patient, end-of-life discussion, and that's really where I learned the basic tools, which I think each of us then refine over the course of our clinical experience. But I think probably the earlier the better in medicine. It would be to bring these discussion and these skills, because they are very much needed, especially with an aging population where we have more and more of these type of discussion for a variety of disease and conditions. So I would say oncologists probably have an excellent training, because we are facing patients with more lethal disease than many other subspecialties. But at the same time, it's something that every physician should become very comfortable with.
Thank you. Since he mentioned Memorial Sloan Kettering and helping him in fellowship, Dr. Abou-Alfa, how did medical school prepare you for tough conversations?
So, as I mentioned in the beginning, I went to medical school overseas at the American University of Beirut. And this is actually, it's a New York State licensed and established university that actually is older than Sloan Kettering, has been in Beirut, Lebanon for, oh my God, like close to 140 years, 1866.
Wow.
And if anything, it really, at the hand of the founder, Dr. Daniel Bliss, and other physicians and professors, they really made sure that they bring the East and West together. And I would say that the school had a clear perspective and making sure that we really always read the patient perspective. And for that purpose, I would say we were engaged already in discussion of that nature, which of course evolved over time in regard to the more subspecialties that many of us have done. And definitely this was clearly further enhanced by the work at Sloan Kettering. And no doubt that you learn mostly, that's all of that, you learn from your patients. These are really the important kind of like guidance for how to engage in those tough discussions sometimes.
Thank you. All right, Dr. Liao, how did medical school prepare you for tough conversations?
Yeah, I remember actually in our medical school in second year, we had this class where there will be fake patients, and one of the assignments or one of the tasks was to do a scenario where you give them bad news, and they actually gave us a script. You set the stage.
They gave you a
summarize,
script. Wow. Okay.
But so it was an introduction, but the other speakers have said, it's something that you continue to refine your skills. You learn from your patients. You get better the more you do it. And when you have the privilege of actually knowing and having an existing relationship with the patient, that also helps, because then it helps you kind of, read them and help you kind of modify your delivery, because not every patient likes to hear things in the same way. So.
Thank you. That's fascinating that you got a script. Dr. Yarchoan, last but not least, how did medical school prepare you for tough conversations?
I think I'm going to end up saying what others have said, which is the short version is it really didn't. We certainly practiced. They gave us a script called the Spikes protocol, which sort of explains the step-by-step process of delivering bad news. But this is not a skill that you learn in medical school. This is something you refine over a lifetime. And I feel like I'm still working on this.
Oh, that's so humble of you. I know one doctor has said to me that medical school teaches you the science, but actually practicing being a doctor teaches you the art of being a doctor, including having those very tough conversations. So I want to thank all of our doctors today. If we could give them all sort of a virtual applause. Thank you so much, Dr. Liao, Dr. Pasche, Dr. Abou-Alfa, and Dr. Yarchoan. And if you're watching the replay, just know if you have a question that you wanted to answer, you can just jump from one question to the next. Again, please do the last poll that we have up. How much has your knowledge about HCC providers and what they do increased? And thank you so much, all of you, for your work in HCC. It's so desperately, desperately needed. It's, as you know, one of the only cancers continuing to rise in the US and worldwide. And so I feel like we need all the help we can get. If you joined us live today, thank you so much for coming. Please support Blue Fairy by clicking that green button at the bottom of your screen. And I hope everyone has a fantastic weekend. Again, thank you to all of our panelists. Take care, and we're going to end this live stream right now. Bye-bye.
Thank you for having us.
Thank you.
Thank you very much.